Well, welcome. Tonight we're going to go over an area that few of us could ever explain. We're going to talk about urgent care. So first, let's start with an introduction.
My name's Christina Oreo. I'm the medical director at AFC Urgent Care in Waltham, Burlington, Stoneham, and soon to be Bedford.
Christina, I got to start out with a question. What is urgent care? I mean, anytime I need care, I got a boo-boo, to me it's urgent. But there's got to be a better definition than I hurt my thumb.
So everyone's definition of what is urgent and what is not obviously varies, but in general, urgent care is the treatment of non-life-threatening illness and injury. Non-life-threatening illness and injury. So we in our clinic see patients who are 6 months and older, and on any given day we'll see such a wide variety of patients, anything from strep throat to a broken arm.
But it's not primary care. It's not like I go every 6 months to my physician to be told I'm a fat old man and I should lose weight.
No, it's not, although I will say that there are many patients that use us for primary care, and they have a very hard time getting in to see their primary physicians who they're very loyal to. But as we all know, it's getting more and more difficult for primary care physicians to really take the time that they need with their patients, and their panels can be very, very large. And so some of those patients do come to us. But in general, we're seeing patients for that urgent condition, and then they may be repeat patients in the future, but their conditions are still urgent, not the chronic conditions that they might see in primary care.
But now the mix. I mean, we're fortunate in Milford that Phil Ceramacoli and his group seem to employ 90% of the primary care physicians. Mm-hmm. So he keeps adding them on. But you know, you hear, who should I go to? Go to Dr. So-and-so. Mm-hmm. No, practice is closed. Right. They can't take any more. Is that the kind of people that would go to your clinic for primary care?
So we do capture some of those patients, but our ultimate goal is to treat their urgent condition, and then if we can, get them set up with a new primary care if they need it, so that they can get that proper long-term monitoring, things like routine vaccinations, monitoring for their hypertension, congestive heart failure, and anything like that. So those are the kind of conditions that we really don't manage on a long-term basis, and we want patients to get proper care for that.
So now let me ask you a dumb question. Why do I need urgent care? I have the Taj Hopkins for emergency.
Right.
I've got primary care physicians for boo-boos and normal. Why did urgent care even come about?
You know, urgent care came about because we needed an affordable, convenient, and very efficient option for medical care. You know, I moved here from Texas about 5 years ago, and when I first arrived here, there were no urgent care centers. There were in Texas, where I was, but not here. And now, most of us can recognize them, you know, all over the place. There's a reason for that, and I think patients really demanded that affordable, convenient, and efficient care that they maybe weren't getting. And with everybody's busy lifestyle now, we really fit into that. So I think that's why urgent care did evolve.
So it is an alternative to the ER.
It is for certain conditions. Now, certainly if you came into the center and you had chest pain and I was concerned that you might be having a heart attack, the ER is the right place for you, and that's where you would go. But if you had the flu or a fever that you couldn't explain, or Lyme disease, or you had a deep laceration that needed to be sewed, urgent care would be the right place for you. And we're very, very affordable. We're much more affordable than the emergency department for those non-life-threatening conditions.
Well, I've seen some of the insurance companies are trying to make it less attractive that if I have my boo-boo, mm-hmm. that I run to the ER.
Right.
Or if my daughter, you know, and at that point, anything to do with my daughters was urgent. They bruised their leg at soccer, it's urgent.
Right.
But it was like $200, $300 deductible.
Right.
To go to the ER. How does that compare to going to your urgent care center?
So in urgent care, the copay is typically like a family practice copay. So on average, it's about $25 in comparison to the emergency department, which is typically $100 or more. So $25, and we do accept all insurances. For those who don't have insurance, there's a fee-for-service option that's also very affordable. So we really feel that we can capture a lot of patients and really offer health care to all.
But you're talking about 25% or less than going to an ER.
Right. right? And the healthcare plans really like us for that reason, because overall we're actually saving money in healthcare by offering these services to patients.
Well, we're seeing even the local med center
Right.
in Hopkinton, the next town over, which is outside of Milford at the center of the universe, but it's only 3 miles.
Right.
They're setting up these clinics, and I assume that means like an urgent care.
Right, sometimes called a fast track, or
Right.
they'll have an urgent care section staffed by different physicians than those that are in the main emergency department. And I think it's helpful because it does offload some of that patient volume so that the physicians and the PAs and all the ancillary personnel can do their job saving lives and dealing with really, really sick patients.
Yeah, so somebody gets into a horrible car accident, they're not going to your place.
They're not. You know, if they have a fender bender and or they've had a
I hit the windshield, I got a bruise.
Exactly. We are happy to see those patients, and it's completely appropriate. But somebody who's been in a multi-car pileup, you know, they need life-saving care, and the ER is definitely the place for them.
But now, the impression people could walk away with is, now wait a minute, I can go to the ER, or is urgent care junior varsity? You know, I mean, from a credentials point of view and experience point of view, you have the same level of people at urgent care as you do as an ER, don't you?
We do. I think that's a great question. So one thing that's very difficult for patients to kind of accept the first time they come into our centers is that we are in a retail center. So my centers are located in an area where there may be another, you know, Panera or a Five Guys or a Party City right next door. And particularly in this area where we have such a high level of academic medicine and larger medical centers, it's so difficult for patients to say, wow, well, it's the same quality of doctor here.
And I think that's the key, because you
Yeah.
sit there and say, no, wait a minute, if I'm paying a fourth, am I getting low, you know, I don't want to be mean about it, but am I getting almost physicians
Right.
who couldn't make it in an ER setting? Or is it sounds to me more like it's the scope. If you stay within these boundaries, you get the same level of care.
Correct. And I'll describe my team so you can have a sense of where these physicians are trained and their background. So I have a team of 21 providers, staffing all 3 of my centers, soon to be 4 centers. And they have backgrounds in emergency medicine like myself. Some of them have up to 30 years experience in all our local area hospitals. I have internists, family practitioners that have worked all over the local area at our biggest hospitals, and they're really excellent providers. My PA team, the same. They have tremendous experience. I would take my children to see any of them. They're quite good. And I do think that you can get that excellent care even in this atmosphere, in this environment.
You know, I think it's all image. Because,
Yeah.
you know, if I'm going in and you're next to a Panera Bread,
Yeah,
well, it just doesn't feel as impressive
right.
as walking into the new, you know, ER center. And you just can't help but draw conclusions like, am I getting shortcut of medicine?
Right. But I think once you walk into one of the centers, you'll see it's beautiful, it's absolutely spotless, it's comfortable. There's nice music playing in the background. We've tried to make it very comfortable for patients. They're not in the waiting room long. The average door-to-door time in our center is 45 minutes, and that includes if you're getting x-rays, if you're getting labs, 45 minutes door-to-door.
Friday night in the ER, I can't get somebody to look at me in 45 minutes.
Correct.
So realistically, it's all the same MDs. It just, again, if there's, you know, Jeff Hopkins has got a staff and equipped for 100 different options. You're saying, no, you focus on 30 of them or 40,
That's correct.
but you get the same level of attention, and I don't have to wait hours. Boy, that sounds like a winning idea.
So what in the Milford Emergency Department, you know, they have advanced imaging, monitoring medications, things like that. What we have on our site is we have a small lab, what we call a CLIA-waived lab, so we can do rapid testing on site.
CLIA-waived?
CLIA-waived. And so CLIA...
I've never heard of CLIA-waived. I've heard of CLIA-cap.
Right.
I've heard of JCO. What's a CLIA-waived?
So a CLIA-waived lab means that we have licensing and permission to perform things like rapid pregnancy tests, mono, strep. We can do rapid HIV, Hep C, flu
So
testing.
like low and moderate clinical assays?
Only the low. So
Okay.
our Waltham location is a moderately complex lab, and we can do CBC and chemistry there on site as well. But the remainder of our sites are CLIA waived. We also have an X-ray on site, so we can do all our X-rays right in the center.
So you're just not doing the high complexity assays?
Correct.
A lot of the ELISAs, the RAs that are done at full CLIA cap labs?
That's correct. So for those tests that we need, we send out to Quest, and the turnaround time is just a couple of days. So we can order those labs if we'd like, but they do come back in just a few days, not on site, same time.
No, we knew that well between Quest and LabCorp.
You're right.
Taking care of all the physicians. Then we'd go down to the hospital and it was Mayo or ARUP.
That's right.
Because they weren't competing for the physician business.
But if you needed an X-ray, I could have that done and read, door-to-door time less than 45 minutes on average. So it's very helpful. So if you're a patient that would normally go to see your primary and your primary needs an X-ray for you, sometimes they send patients to us because it's very convenient and it's easy.
But it almost sounds like, when we look at the Milford Medical Center, they do a certain amount of procedures. Anything that really is very, very specialized, they may refer to the Farber.
Right.
It sounds like you're the same model, just further downstream.
That's exactly right. And we've developed very close clinical referral relationships. And so, for example, if you had a bad hand injury, and I had to manage that acutely, got your X-ray, managed whatever kind of wound you had, your fracture, I can get you same day, next day follow-up with a hand specialist. Or if you had a skin condition, I might be able to get you follow-up with a dermatologist.
Wait a minute, I can't get next day access to, somebody on hands. How do you do that?
It's a huge advantage to our patients. We've spent a lot of hours developing these referral relationships, and it hugely benefits our patients. So even patients that come in, about 30% don't have a primary care provider, and we can make those appointments. And so we can schedule their PCP appointment for 1 week later. And now at least these patients have access into the system. They would be otherwise lost.
Now that's amazing to me, because we spend all this time talking about how wonderful it is in Massachusetts that 90-odd% of our residents are covered. But you're saying a third of them don't have a primary care physician routinely available?
That's true. And I think part of the reason is we're capturing patients who are just moving to the area, who maybe haven't had a chance or don't quite have the knowledge yet for how the system works and how to get on the connector. And so we do see those patients. We also see patients who are maybe in limbo and they're going to be here for 6 to 12 months, and they won't necessarily sign up for insurance. And some patients,
basically the parents who don't have kids who play soccer.
Right.
Because everybody that I've talked to, any of the MDs, seem to say their greatest referrals are the sidelines of a soccer field.
Sure.
When one mom talks to another mom.
Right.
And I can say it as an old man, usually the moms will tell you, you're going to so-and-so.
Right. Right. Well, I have to say, one of the things I love most about my job is working in my community. And so I have school-age children, and I get to know all the parents, and I get to see all the children who come in injured at their soccer games and baseball, and we're open till 8 to 8 every day. And so if it's, an injury that occurs at 6 o'clock at night, 7 o'clock at night, well, we're open to deal with it. And that's a big shift from primary care as well.
Well, it really sounds like you're giving the benefits of convenience and cost, but not giving up any of the quality or, because obviously we all want to save money.
Right.
But if I think I'm cheaping out my daughter's health care, I don't care what you charge, I'm not going there.
Yeah, I think that's absolutely true. And so my goal as the medical director of these centers is to make sure that the care is excellent. My expectation is that we're practicing evidence-based medicine the same way we would in a big area hospital. That's my goal, that is my charge. And so I do a lot of quality control. We do a lot of education in our staff meetings to stay up to date and to make sure that we're practicing very uniformly and practicing correctly.
No, I mean, that's the FDA guidelines years ago shifted to evidence-based.
Right.
You sit there and say that is the trend, whether you're at man's greatest hospital, MGH, or a community hospital.
I agree. It used to seem we practiced medicine based on dogma, but evidence-based medicine really came into vogue when I was a resident. And that's the
You
standard.
worry about some of the dogma too, because that was always the question. Okay, I hurt my knee. Okay, am I going to somebody who's been, you know, an orthopedic surgeon for 30 years?
Right.
Do I think they're up to date on the latest?
Right.
You know, or do I go down to Mulroy and say, okay, who you got that's young that really knows what he's doing, or she knows what she's doing?
Right.
So the dogma thing really is worrisome.
It is, and I think, I mean, the standard now is 99% of physicians, I think, and medical professionals as a whole are practicing evidence-based medicine, but, you know, it's the leadership in any organization that needs to make sure that the quality control is there.
But now, Christine, how do they do that? I mean, we're seeing, especially on the primary care level, the trend towards, you know, how do I put this? Ford-type medicine. Punch out a car every 30 seconds, no matter what. Make it all black. You say, okay, physicians, we want you to spend no more than 13.3 minutes per patient.
Right.
When do they have time to stay current?
Well, it is a challenge. It is absolutely a challenge, but it's critical. And we offer CME to our providers, and, you know, we hope they do use it, and so they take time to go to conferences and stay updated. But, you know, that is the challenge, I think, in emergency medicine and urgent care. You have a very finite amount of time to make a connection with a patient. You may have 9 rooms full. You're seeing 4 to 5 patients an hour. And, you know, you need to go into that room, make a connection with that patient. You may only have 5 minutes or so. But in that moment in time, you need to be able to address their concern, whether it's a sniffle or a really complicated laceration that you're going to be sewing up, and let them know that in that moment that's the most important thing that you're doing, regardless of what's going on outside.
And that's going to be tough. I mean, we always joke, in Milford, 4 physicians brought everybody into the world when we were kids. Capisi, Cicchetti, I mean, Mastriani. You go right down, and one of the 4, those were your only choices at the Little Red Hospital called Milford Hospital. So you knew you couldn't put anything over on them because, you know, they would use the old line, I brought you into this world, I'll take you out. You know, it's like, okay. But how do you really get a feeling for the patient when you just met him or her, and you may not see him or her again? What is the art to understanding a patient?
It really is the art of medicine, and many providers will have it, and some don't, you know, and so those that don't probably aren't suited for urgent care and are suited for other wonderful areas of medicine. But the people that we're attracting are those that can really be in the moment. They're good listeners, and, you know, most of what you learn really comes from the history. It's about listening to the patient. And many times I'll be with a patient and we'll get into the conversation about what's been going on and what their symptoms are. And I'll say, so what's your most prominent concern? What's bothering you the most? What is it that brought you in today if your symptoms have been going on for 10 days rather than last week? And they kind of say, oh, I thought you'd never ask. You know, it was this, you know, and they'll go ahead and tell me. And it's a big sigh of relief. And I think, you know, most of my team, my whole team can do that. And that's what attracted me to them to hire them. That's the skill of an urgent care physician. And I think of an ER physician as well.
No, I would think it's almost the same.
Yeah.
You know, again, I think the misunderstanding is it's not the level of care.
Right.
It's the scope of care.
Right.
You just don't do everything. They can do it. You know, you don't have $2 million Da Vinci robots and all sitting around that you have to charge for.
That's correct. So we don't have the resources like a CT scanner and an ultrasound and things like that. And so, you know, I have the utmost respect for what happens in an emergency department, being that that's my background as well, and the heroics that happen there every day. That's just very different from what we do, although what we do is kind of a subset of what happens in the ER as well at times.
But my understanding is if you found something, you get to a point where you say, oh my God, you're outside of our scope. You can put them in an ambulance, get them to the ER.
Absolutely.
I mean, if you can get me an appointment with, you know, Jeffrey Dietz in a day instead of a week, then you can probably get me in the ER pretty quick too.
Absolutely. So, and that does happen. I mean, we do have some weeks where we're sending many patients to the emergency department, depending on the acuity. And then we'll have weeks where we're not sending anyone to the emergency department. So it definitely does happen. And in those cases, we've evaluated the patient. We send the patient with a copy of their chart, any x-rays or any EKGs or lab work that was done. And then we call ahead to the emergency department to speak to the physician or the physician assistant who'll care for the patient and let them know who's coming, what the situation is. So.
No, but your centers have to relate to a number of different hospitals and medical practices.
Correct.
How do you deal with the EMR, the electronic medical record issue?
Mm-hmm. It's challenging. I mean, our EMR does not kind of meld in with some of the other EMRs in the area, and most don't actually, you know, candidly speaking, from hospital to hospital. So what we do is we populate the EMR with all the data and then print out a hard copy.
Oh, okay.
And then we can either send it with the patient or send and fax a copy over as well.
So it's the old sneaker net. Carry it with you.
Carry it with you. And for our patients that come in for urgent problems and conditions, at 2 o'clock in the morning every night, a copy of their chart gets faxed to their primary care doctor.
Oh.
And that's really important because when I do speak to PCPs, what they do tell me is, you know, oh, we're worried about the continuity of care. We want to make sure that we know what's going on with our patients, and that's very, very important to us as well. So we make sure they have the chart and the information, and we're always available to speak with them as well.
It's amazing how much is still done by fax in the medical industry.
Isn't it? Secure fax.
Yeah, I mean, you keep getting this HIPAA thing, and I said, wait a minute. If I scan it and send it by email,
right.
Isn't that easier than faxing it to you? And we don't have a secure email
It's
system.
not secure, that's right. We actually, in our EMR, we have a secure link that gets sent to every patient, and they can see a copy of their record through that secure link. And I think many EMRs are going towards that now so that
Sure.
patients can access their records in a timely manner.
Well, I just have this hard concept that, okay, so if I'm sending electrons through a telephone wire, that's secure. But if I'm sending them through a cable, that's not secure. It's like, I'm sorry, it's what's on either end.
But you can't hack into a cable, I don't think.
I don't know. To me, it's encrypted on both sides and life is good, but who knows? You know. Demographic-wise, now you've mentioned that a lot of the patients are, I just came to the area, I don't know, you know, God forbid, I don't have children, so I can't go to the soccer field and ask everybody. A third of your patients don't have primary care. Is this because of economics, mobility? I mean, it just seems amazing to me.
It is amazing. Also, a good percentage of our population is younger, and so I think a lot of the younger population in their 20s doesn't really feel they need a primary care doctor. And you know, they're not getting a lot of routine testing.
Right.
They've been through all their childhood vaccinations. They're in a time of their life where they're not getting ill. And so they don't need a primary doctor, but they really do need a primary doctor. They just don't think that they do, and so they do come to see us.
It's funny because the local pediatrics group finally sent my daughter a note saying, you're 26 years old. Right. You need to go and get a big person doctor.
Right, right.
And to her, it was just, wait a minute, I've been there since memory.
Right.
You know, she started there, and until they threw her out, she didn't have an OBGYN that was for adults.
Right.
So you're right, I hadn't thought about that. She just never needed one, so why bother?
Right, it's like the 22 to 35-year-old age range. And then beyond that, I think people start to realize that they really do need some routine follow-up and care. Or they need a tetanus shot and they come in and see us, and then we say, do you have a primary care doctor? And it may kind of spark something in their mind to say, hey, maybe I really should get some routine care.
So then you can put them in touch with PCPs that are
Correct.
actually accepting patients.
Correct. Correct.
Well, that's good.
Right. So I do think that's a huge service to our patients. And then, of course, the specialty follow-up is a huge advantage as well.
Now, economically, you know, I've had so many of the physicians say, I could fill my practice with Medicare and Medicaid patients and go out of business.
Right.
Does that work the same in urgent care? Do you have a larger percentage of Medicare, Medicaid, or less?
So currently, a large percentage of our patients are insured. But we do accept all insurances, and we do accept Medicare, and we will be accepting Medicaid in the coming months. So that's something we've really been pushing for. There is a referral requirement with Medicaid, and that's really been something that's been a challenge for us because we are a no referral walk-in clinic. So our hope is that will change.
If I don't have a primary care,
right?
How do I get a referral?
Well, that's a great question, and there's the conundrum.
I was going to say, wait a minute, I need a referral, which I got to get from a primary care, but nobody's told me how to get a primary care, so.
Right, and if you have an urgent problem, if you have an injury, getting a referral at that moment in time is almost impossible. What if it happens at 7 p.m.?
Well, that's, my next question was, okay, so we're playing soccer on a Friday night. Daughter twists ankle, hurts. We go to you. I'm not going to be able to get my physician typically on the phone.
Right.
Or I got to get an answering machine, and the poor woman has to call me back within the hour. By then, I'm freaking out because my daughter is crying in pain.
Right, and so it seems almost impossible. And so some patients in that situation might opt for the fee-for-service option that we had, which is very affordable. And so that's just kind of one way to help that situation.
Is it as bad as people portray the Medicaid? When I was running the clinical lab, Medicaid was the worst. Medicare was a little better. And then your private insurance made up for it.
Do you mean in terms of reimbursements?
Reimbursement.
Yeah, Medicaid reimbursements are typically the lowest reimbursement, unfortunately.
But are they covering your costs?
Hard to say.
Yeah. So that's what I keep hearing. It's like, sometimes.
Yeah, sometimes.
But, 40% of the patients or whatever it was are covered by Medicare or Medicaid.
Right.
So you can't wipe out 40% of your market.
You absolutely can, and everybody deserves quality health care, and that's really how we feel. And so we want everybody to be able to access our services.
Yeah, and that's always been something that, here I can only speak for the people I've interacted with in Milford, where Jeff Hopkins will tell you we're need blind.
Right.
Once they make it past the front desk, we don't know if you're a billionaire or a working stiff. We're taking care of you.
Right.
And that's the way it should be.
And that is why, the emergency departments in our country are, in my opinion, an essential public service. And I hope the public sees it that way, but they are really heroes. And they do see anybody that walks through those doors. Doesn't matter, what the insurance is or anything like that. And they're required to, by law, to do at least a screening exam, but they do see anybody. It's need blind, as he said.
Well, think about it. Do you know of one, there's probably one out there, but one physician who would worry first about financial reimbursement versus patient health?
No, it's unimaginable to me.
First of all, you're spending half your life in school. I always got a kick out of it. The only ones that amaze me more than MDs are the mudfuds, the MDs, PhDs.
Yep.
Because the MDs come out, and to me, they're halfway towards retirement before they can earn their first dollar. The mudfuds, I think they are ready to retire when they come out. But to spend that kind of time.
Right.
And I work with a lot of kids at Holy Cross, my old school.
Right.
And you try and tell them that if you're going into medicine today because you have a passion for it, great. If you're going into it because you want to make a good living, don't.
Right. So you will always have a job. I think it's safe to say that if you're in the medical profession, and that means physician, PAs, nurses, I think your job security is excellent, but you need to go into it for the right reasons. And medicine's a wonderful field. I think it's a privilege to care for patients and to be able to kind of see them at a vulnerable moment and really try to help them and diagnose what's going on with them. It's a really rewarding career. But you need to go into it for the right reasons.
But you have to have that passion.
You do. You absolutely do.
Because if you just are into it to make money, there's a lot of other professions that, I've always said the MDs work way too hard for not enough money. Middle of the night getting a phone call at 2 in the morning. My daughter's coming. I have not had many of those in the business side. There's nothing usually that urgent that can't wait a couple hours.
And I think, too, patients can sense when a provider is happy, content, enjoys their job. You can sense it. And so in my line of work, we really try to hire people who love what they do.
Well, you could see it. You may know that other Dr. Oreo.
I do.
When I referred to him as a farmer, and he just looked at me and said, well, you run around planting seeds. Isn't that, I mean, how do you explain to somebody, I'm a farmer, I just
Right.
plant radioactive seeds.
Right.
But you could see the passion, how much he cared. And yet he had a sense of humor.
Yeah.
Because I don't think he really ever was referred to as a farmer before.
No, I don't think he has been. He probably loved that.
So now, typical day. What takes up most of your time?
So if I'm seeing patients clinically, certainly that takes up most of my time. But there's a whole other administrative side to my job, and actually managing people takes up a lot of time. And that's kind of twofold. So it's managing the human resources side of the staff, recruiting and finding new providers, medical assistants, nurses. And then also that quality control that we talked about earlier, that's a very big part of my job.
Well, let's look at the clinical.
Sure.
So your staff, typical clinician that works for you.
Yeah.
What would be the thing that keeps him or her busiest during a normal day?
Sure. So you'd come in the morning, and your first couple of patients may be a strep throat, maybe a urinary tract infection, a respiratory illness, the flu, bronchitis, pneumonia. You're looking at x-rays, you're interpreting labs. And then in that mix, there may be someone who comes in with arm pain after they fell off the jungle gym, a laceration, an abscess perhaps, skin infection. And then throw into that, there's some occupational medicine as well, and travel consultations that we do. So we are all DOT certified medical examiners in our facilities, and so we do the physical exams for all our truck drivers, bus drivers in the area. And that's a federally mandated program, training program that we've taken in order to certify these men and women. So we do those physical exams as well.
What are you certifying me? I'm going to drive a truck.
Right.
Okay, I'm ignorant here.
Uh-huh.
What certification do I need?
So if you have a commercial driver's license, so you drive an 18-wheeler, for example, you need a very specific, it's a general physical exam, but if you're seen by a DOT medical examiner, you get also a urine screen, blood pressure, vision check, and hearing check. And all of those have to be within a certain very tight range in order to be passed. And if you have other medical conditions, then you need to see your specialist, make sure you're cleared and safe to drive a vehicle.
So you're doing like a drug of abuse screen?
On some patients, not all. So the general urine screen is really screening for blood and glucose. So if you're diabetic, then if you're insulin dependent, you may not be able to pass a DOT exam. If you're not insulin dependent, then you can pass, but you have to have very tight glucose control. If you have any kind of heart history, you'll need to see a cardiologist.
Are they worried that you'll have a heart attack or have a stroke while you're driving?
Absolutely.
Oh, that makes sense.
So if you think about it, it's hugely important because you're driving on the road with your family, and you want to make sure that the school bus drivers are safe, the truck drivers are safe and healthy enough to drive these vehicles.
It's almost like a Corey check physically.
Right, right.
There's nothing specific. You just want to make sure that I'm not going to pass out while I'm driving this monstrous truck.
Exactly.
Okay.
So that's some of what we do. And then we also do some travel medicine. So if you're going to Africa or any other country, we utilize the CDC recommendations to say, hey, you need malaria prophylaxis, or you might need yellow fever.
Yes, when we went to Brazil, I had to have all sorts of nasty harpoons.
Yes, yep.
The yellow fever and all this
Yes.
nonsense. It was like, okay, why do I need this?
So we do all of that. We do all of that as well.
Now, kids versus adults, percentages?
So in our Waltham and Burlington locations, we see probably 20% pediatrics. And then in our Stoneham location, we see, I would say, 10% more than that. So probably about 30% pediatrics in that location. So it's a little geographically dependent. But again, it's 6 months and older that we see.
Well, that makes sense. I mean, I would think, you always take care of your kids better than you take care of yourself.
Yeah.
I'm going to make sure that there's a primary care for my daughter, even if I'm silly and kind of skip it for me.
Yeah. And interestingly enough, in that population, most of those folks do have pediatricians, because that's always our first question. Do you have a pediatrician? And they do, but they often can't get an appointment.
Oh.
And that's why they're in our center, to get the strep test, to get that x-ray for whatever injury may have happened.
Is it getting worse in your mind, the percentage, as we cover more people, which I can't imagine everybody thinks is a bad thing. You know, universal health care, you can argue how it should be delivered, but I've never heard somebody say you shouldn't cover people.
Right.
But as we add more people to the mix, is it getting harder and harder to get appointments?
I think it is. It certainly seems that way based on what I'm seeing in our centers. I mean, I think the pediatricians, any primary care physician, their panels are getting more and more full, or they're closed, and patients just can't get in.
But that just seems strange, because normally supply and demand. If there's a big enough demand, you would think the supply of pediatricians or primary care would increase. Yet Phil Sermacoli tells me his hardest recruitment job is to get primary care physicians.
There's definitely a shortage. There's definitely a shortage of primary care physicians. And where I went to school at the University of New England, they definitely made us aware of that, and they were really trying to get us to become primary care physicians. But there's a shortage, and it's really affecting medical care.
Money, prestige, what is the combination driving people away from it?
Yeah, I can only speak from personal experience and speaking with my colleagues, because we do have several internists and family practitioners on our team, and there's a lot of administrative burden. The hours are very long. I think that, and I'm just speaking from my own personal experience and not for any other physicians, but from what I have heard, that the patient interaction time is not very long, but the administrative burden for each patient is very large. And that can be taxing, particularly as you get older in your medical career. And so we tend to get a lot of physicians that really want to practice medicine, I think, in its purest form, which is really spending time with the patient with very little administrative burden.
Well, see, I think that's the whole Tri-County lure, you know, is what lures you in is, okay, I've just spent 10, 12 years learning how to take care of patients.
Right.
And if I can have 30, 40% more time to be with a patient,
Right.
and not have to deal with chasing Mrs. McGillicuddy for her $13 copay or, you know, all the admin burden, that's just got to be an incredible attracting force.
It definitely is, and also there's no call. You know, we're open 8 to 8, but none of our physicians are taking call. And so they don't have that burden, which I think becomes more cumbersome as physicians get older. And from the ER perspective, I do have several ER physicians on the staff. You know, the night shifts and the really late nights can get taxing after a while. And once people have families, they don't always want those long hours overnight anymore. And we certainly need those physicians in the ER to work those shifts and save lives. But, you know, when you're open and during sane hours, 8 to 8, that does attract a lot of physicians who really want to get out of that type of lifestyle.
And actually go see their family?
Yes.
But now, again, you seem like a bridge, because the 9 to 4 primary care, the 24-hour emergency room, you seem to fit in the middle. What happens if I get hurt at 9:30 at night?
Well, you're probably going to the emergency department.
Okay.
Or you're going to wait till the next morning. And it really depends, you know, whether it's a very urgent condition that can wait or if it can't.
No, that makes sense. But realistically, you're saying we're going to take, you know, 12 hours of the day. If it happens in the other 12,
Right.
if you can't wait, you know, if it happened at 8:02, you may have to go to the ER.
Right. Right.
So what caused you to do urgent care?
Well, I practiced emergency medicine for about 12 years, and I loved it. I love the ED. I love the medicine side of the ED. But I was looking for a bit of a change because I have 3 young children. And I was one of those people who was saying, you know what, these night shifts and shifts till 2 in the morning and changing hours all the time is just not working for my family. And as you know, my husband's a physician as well, so 2-physician family. And so I looked into urgent care, and that was very, very new a couple of years ago when I looked into it. Plus, for me, what attracted me to AFC Urgent Care was the option for becoming the medical director, which was kind of branching out and a whole new skill set that I would be learning, and that's been very exciting.
Now, is it hard to manage MDs? I've been told it's like trying to herd cats.
It's challenging. And to be clear, we have MDs and DOs. I'm a DO. But it is hard. It's hard because, you know, physicians, we all have a lot of training. And I have some physicians on my team who have, you know, 15 to 20 years more experience than I do. And I think coming into this, that was my biggest fear was, can I lead this team?
Sure.
Being that this group of people may have more experience than myself. But I love working with them, and I think you have to have the leadership skills, or you develop those leadership skills over time. And they've been very responsive. They love it.
In any industry, in any discipline, you're going to have people who are much better than you at a certain skill. Doesn't mean administratively they could stand it.
Right.
So, you say you got somebody with 20 years more experience than you, they probably don't need to go to you and ask for medical advice.
No, they don't.
But on the other hand, they're probably not the ones that are going to make sure that the machine is running well.
Right, and candidly, many of them really have no interest in an administrative role. They really want to just practice clinical medicine, and that may be why they left their practice,
right,
or left the emergency department, and they really want to just see patients. And so they're happy that I'm handling all that other stuff. And what I love is that everybody brings something different to the table. If I have someone trained in internal medicine and pediatrics, and someone in the emergency department who's been ED board certified, internal medicine, FP, they all have a different perspective, and they really bring a nice background to our practice.
So you went to school, then you did a side trip to the Middle East?
I did a side trip, not a vacation, to the Middle East. So I got an HPSP scholarship through the Air Force to pay for my medical training. And that's how I got through medical school. So when I finished my 4 years of medical school, I went to an active duty emergency medicine residency, internship and residency, and that was in San Antonio, Texas. This was a joint operation between the Air Force and the Army. And that's where I did my active duty residency. And from there, I went on to serve for 4 years active at various places in the country, but then I did serve some time overseas.
In Baghdad?
I was in Kirkuk.
In Kirkuk?
Yes. You're familiar with Kirkuk?
I'm familiar. I've been there maybe, actually Kirkuk maybe only 3 or 4 times. Did you get to go to the Baghdad Fair?
I did not. I was in Kirkuk the entire time except for patients that I flew down in helicopters down to Baghdad and to Balad, which was the Air Force's and Army's main medical center down there. But the Kirkuk Medical Center was very small. You had the base, and then you had a wall, and then you had the city of Kirkuk. And we had 2 small ORs and tents. It was interesting. It was a very interesting and rewarding part of my medical career.
There were no Army bases there from the U.S. when I went there in the 80s.
Yeah.
It's probably the strangest feeling is being in a country where you don't have diplomatic relations. We went to the Baghdad Fair, which amazed me. Because here we are with scientific equipment, HPLCs, liquid chromatographs, trying to demonstrate them and sell them. Right next door was the East German Caterpillar equivalent with the big machines, and just down there were people selling goats. It was the most bizarre experience in my entire life.
It does have you take a moment to pause and say, this is just crazy. And I wonder how you kept the sand out of your equipment when you were there.
We literally, cost us 10 grand, we built a building and had an entryway, and that was the only way, because you'd have to filter the air coming in, because otherwise it seemed like sand got everywhere, no matter what. So this way, at least we kept the booth clean.
One thing I never saw when I was there was a sandstorm. I'm sure did you experience?
In Saudi, I've seen them, which was a frightening thing, because it was just, you see it in the movies with the dark. No, we really didn't. We ran into a little crazy weather when we decided we should go see the Gates of Babylon. So my darling bride and I got a cab, and we went up just to say we've been there. Or to go to Samara, that famous baby food factory.
Wow.
I don't ever remember seeing baby food in the chemical plant we were at, but they said it was a baby food factory.
One of the things that was interesting when we were there, we actually taught an EMT basic course to Iraqi men who were working on the pipeline, the oil pipeline, because this oil pipeline was so vast that these men, if they had an injury or some kind of accident, they were so far away from medical care. So we were just teaching them basic EMT skills. That was a very interesting experience. So my team and I taught them with the help of a translator in our tent. So they actually came onto our base for the course, and that was about a 2-week course. And then they took those skills and they applied the train the trainer approach and trained their colleagues.
That's wild.
Yeah.
I remember the first time I went to a refinery. I had just left Dammam, the eastern side of Saudi, and it was a 2.5-hour drive. They handed me a phone, one of these satellite phones.
Right.
And I said, why do I need this? They said, because if you get stuck out there,
Right.
it could be a day before somebody travels that. Because everybody did the helicopter.
Yeah.
Bumblebees, they're not meant to fly. I keep looking saying, bumblebees weren't meant to fly.
Right.
Helicopters get me nervous. I'll drive. And sure enough, you're just driving and it's just sand, and then all of a sudden a big flare.
Yeah.
You said, okay, now I know where I'm going.
Right.
But it was amazing because it was so different when we were there, because as long as you behaved yourself, there was so much security everywhere.
Right.
That you didn't worry. When you were there, it's probably the exact opposite.
It was very different. I mean, people always say, were you on the front line? There really is no front line. As I said, there's the base, there's a wall, and then there's the city. And it's right there, and you can hear it, and you hear everything that's going on. It's just a very different scenario.
I remember one day we were sitting in Kuwait City, and my darling bride was saying, I'm a little nervous about next week. So why? She goes, there's a war going on, because right at the Iran-Iraq war, and we're going right in the middle of it. Shouldn't we be nervous? And I said, wait a minute. Let me put it in perspective. Baghdad, we're almost 50 miles from the front. I said, look over there. She goes, what's that? I said, Basra. We're 12 miles from the actual fighting. So I said, you look at it, and it's all perspective.
It is.
We stayed in our hotels. We didn't wander around too much, so we minimized, the issue. But you never know. When I went to get my visa, for once, I don't know what it was, but I went. And the Iraqi embassy in Paris, they wouldn't let you in because they were worried about terrorism. So I'm standing outside for about 45 minutes. They got a little bank window where you slide your dog. I got bored. I left. The next morning we're riding the train in, and Sharon gets all nervous. Says, where were you yesterday? I said, I'm at the office. No, where did you go? And I didn't know. I don't understand. She goes, did you leave the office? I said, went down to get my visa, but I got bored. About 35 minutes after I left, they blew up the Iraq embassy.
Is that right?
And it was a car bomb. So I don't know if it was the car I was on, but it was one of 4 or 5. And there were like 6 or 8 people that were still in line that weren't anymore.
I think that's the really interesting part about it, is that when you've been in that environment for a while, as I was there for 6 months. So, the first week that you're there, everything, all the noises, you get some rockets that come over and alarms going off and things like that. They're so startling, they're so new, it's terrifying. But over time, it really becomes background noise.
You get desensitized.
You're completely desensitized to it. It's a normal day for you. But I was lucky to be able to call my husband from Iraq, and everybody had pretty good phone privileges and the ability to contact their family. They could hear some of that stuff going on in the background. It was terrifying for them.
Wait a minute, the farmer stayed home and sent you to the front lines?
He was still in his residency at the time.
Wait a second.
Yeah.
I have to talk with Dr. Peter. That one. No, it is strange, because I had a service guy work for me. He came home one night from Beirut, and he said, well, interesting night last night. I said, what's wrong? He goes, I did something smart and something not so smart. I said, really? What? Because, well, we were sleeping in this hotel, and I heard an explosion, and the hotel started rocking. He says, so I did something less than intelligent. I went to the window. He goes, I know, you trained me not to. And saw people shooting small arms fire across the hotel.
Wow.
I said, yes. He goes, then I remembered what you taught me. So I ran to the bed, grabbed a pillow, a blanket, and my briefcase. Because you want your passport and your purchase orders. And I jumped into the bathtub. Because back then, most of these old Middle East hotels had cast iron bathtubs.
Yeah.
So like being in a tank.
Yeah, safest place to be.
He said, I got up in the morning, I went downstairs, typical Lebanese. The front of the hotel is gone. But there's a man there with a rifle and a cigar box. You still had to pay for staying there last night. So now you start thinking about the group, the settings. Where are you taking the company?
So I think that the expansion that we've had so far is going to continue. And right now, AFC Urgent Care is the largest urgent care in New England. We have 21 centers. I manage 3 of those, but there are sister centers across Massachusetts. It's one of the largest pure play urgent care networks in the country. And I do think that we will expand further. My goal for the region is that we are best in class and practicing the best possible evidence-based quality medicine, and that we're the most convenient, most affordable option for our patients. So I think that's where we're going to be in the next couple of years.
When you think about what's happened in clinical diagnostics, the hospitals realized that they had to maintain a stat lab, and it was being used at, less than 100% capacity. So they reached out and started bringing tests in. Do you worry that the hospitals won't set up their own urgent care facilities and compete with you?
Well, they already are.
Oh.
So they certainly are. I mean, Partners Urgent Care exists, and that's in the partner system, and that's near some of our urgent cares. But I think that with what we're doing, that we do it very well. And I think our patients know, and word of mouth speaks wonders and really helps us. So we've been doing it now for over 3 years, and our patient volumes are still going up. And now we are also DPH certified clinics, and so the Department of Public Health has certified our clinic in Stoneham and is soon to be inspecting our other centers, and that's a very big success for us as well. And so I think, again, our goal is to be best in class, and I do think, the hospitals will continue to expand as well, but you have to do what you're doing and do it well. And I think if we continue to do that, we'll...
So now, is your company a for-profit?
Yes, it is.
So you're competing against nonprofits.
Correct.
Doesn't that give you a disadvantage?
Not really, because I think that ultimately patients are going to go where they get the best, fastest care.
Most efficient, highest quality.
Correct.
Care.
And convenience is a huge part of that. So if you walk into a center and it's taking on average 2 hours to get in and out when you have your 3 or 4 children with you on a busy Friday night,
Lord.
You're not going to go back there. But if you're in and out in 45 minutes and you've got great care by an excellent physician or physician assistant and a great team, you're coming back.
Well, I think, Christine, the real thing is the quality.
Yeah, it
As long as
absolutely
the
is.
quality is there. Because as I said before, if I think I'm cheaping out my daughter's health, I'm not going there.
Right.
If I can get the same quality, and then it's faster, cheaper, better.
Right.
Yay!
Why wouldn't you go back?
Well, that's it. So you have to start getting your people, your business development people, to go to the soccer fields.
Right.
And let all the people know who just moved here.
Yeah. And they do that. We actually are quite involved in the community and community events. So we run a lot of local races and festivals. We're involved in that so that we kind of get out there and let people know who we are, what kind of services we have. We do a lot of flu clinics. We're involved in the schools and such. So we get our name out there.
So how would somebody find you? I
So-
mean, do you Google urgent care and?
Yes. I think that is how most people find us. So they do that, and then they can actually get onto an app on their phone and make an appointment. Even though we are a walk-in center, they can put their name in and kind of get in the queue to be seen, and they can do all their registration online. But Google search is probably the #1 way that people will find out where we are. They may say, Google urgent care in Waltham, urgent care in Burlington, and we pop up. And then, of course, it's driving by and seeing it in whatever center we're in, and then word of mouth.
So now how close do you come to Milford?
I'm not that close to Milford yet. we'll see in the future.
But Waltham is
We're about
half hour.
About half an hour. So it's not too terribly far.
Well, no, but especially, let's see, if it's 2 hours in an ER
Right.
and 45 minutes with you, 30 minutes to get 45 minutes, I'm still ahead of the game.
You are. And then, of course, if you have somebody who lives in Milford but they work up north, you know, we do see a lot of people who stop in on their way to work or going home from work or on their lunch hour even.
I hadn't even thought about that because, like, I work above the Arctic Circle in Woburn,
Right.
60 miles away.
Right.
And I would never think of stopping in an ER along the way.
Of course you wouldn't, because you have to spend the rest of your day.
Yeah, my day's gone. I don't have to go to work.
Right. Well, you could come and see us on your lunch hour, because people do all the time, and they're in and out quick enough to do that.
So I'll let you finish by telling people, why should I go to an urgent care facility?
Our patients should go to see an urgent care physician in one of our facilities because you will see an excellent provider. You'll get great quality care in a state-of-the-art facility that's comfortable, clean, beautiful environment, and you'll likely be in and out within 45 minutes. And we accept all insurances with a copay that's a fraction of what you're going to
I'm going to
pay.
say, and it's a regular copay.
It is a regular copay.
I mean, versus this $200 or $500,
Correct.
Discouragement copay.
Right.
Well, thank you for letting us know what urgent care is all about.
Thank you for having me.
And as always, it's always amazing to me the kind of services that we don't understand. I, for one, had no real idea that urgent care meant a limited scope of the same high quality services by the same high quality people that you would get if you went to an ER, but at a much better cost. And boy, I like this idea of 45 minutes.
Right.
So as always, may tomorrow be a better night than tonight. To our 6 loyal viewers, I want to say God bless, have a good night, and thank you.
Thank you.
Not too long since I've been home. Been running all my life just